So I'm going to do a quick few words on Morton's neuroma. What is a Morton's neuroma? Treating it and my thoughts on it. So Morton's neuroma, essentially, if you imagine this as the foot, is a swollen nerve that runs between the long bones of the foot, the long metatarsals. My theory on this and thinking and talk around it is essentially we weren't born with swollen nerves. Why are we getting them now? And modern living dictates that we're kind of hunched over and in a very much tight position with our hamstrings, calves, all very tight around the back. We're sitting at desks all the time. And it's kind of not great. So we get what's called forefoot overload, or the front and ball of your foot loading down, tightness around the back. At the same time, these bones are quite flexible, so they're moving up and down as we walk, and maybe carrying a little bit more weight, like me, and they're loaded up. And as they're loaded up, they catch the nerves on the inside and bottom of the foot, causing them to swell with a bit of irritation. Now this could be the nerve itself, or the nerve in a bag of fluid called a bursa, which is really common to see. So some of the reports on an ultrasound or an MRI scan might show a bursal neuromal complex. Now, Morton is the name given to this type of swollen nerve, so if you hear that, that's kind of what we're talking about. You generally, being a practitioner or a patient, will either feel yourself a swelling and fullness around that area, especially pain on the plantar aspect or the bottom of your foot, and maybe shooting in between the toes as well. And that shooting pain can be quite uncomfortable. Some patients say it's numbness in that area, and it can be quite excruciating and debilitating. My thoughts on this are really, again, going back to the fact that we weren't born with it, and the fact that we have got tight structures around the back, that ideally we can avoid surgery in an ideal world. Getting the diagnosis is key, and I'm delighted to see patients with Morton's neuromas, because there are a few other things it could be, and it's good to get that differential down. For example, the bursa that I mentioned, or a stress reaction to the bone, or a stress fracture to the bone, or a plantar plate, or it's a tissue structure on the bottom of the joint which can be stretched and ruptured, to name a few. So how do I manage them? Firstly, the clinical diagnosis, which is using the knuckle, and the knuckle goes in between the long bones, between the heads, and presses down. As it's pressing down, I'm trying to squeeze the nerve back into the metatarsal heads, or these big boulders that are knocking and causing it to swell. And as you do that, you can press or squash the foot itself. So you're kind of knuckling it in and squashing the foot. It's a fairly sensitive way of diagnosing this, and often you can feel a little bit of a click as well, or a giving in the tissue, which the patient can feel at the same time. It's called a Mulder's click. It's a really nice, neat test. You always feel the calf, because actually you'll notice, most people notice that the calf's really tight at the back. And to me, that's an indicator to do two things. Firstly, nail the diagnosis. My default is an MRI scan, so I generally send patients for an MRI scan so I can see and also show patients at the same time. If you are, and you may use ultrasound and good at it, you can demonstrate a swollen nerve and also measure the size using an ultrasound machine. It's a great way of looking at them and showing patients at the same time. That transparency and understanding, I think, is crucial to recovery. So how do I treat these? So once we've got it, and I generally, like I said, send for an MRI scan, I see the patient, but in the meantime, my advice is to do two things. Number one, lots of calf stretches, hamstring stretches, glute stretches. Ideally in conjunction with a physiotherapist, but time dependent on patients. Sometimes they just want to crack on and do it themselves while they're waiting for the scan result. Number two, a dome orthotics, really simple, really easy to get hold of. It looks like a mouse. It's like a little knuckle that sits not on the ball, but a bit closer to the heel than the ball itself. And it lifts, as you can see, my fingers are dropping, so it lifts and it spreads the bones. It kind of provides a bit of space for the nerve to breathe a bit. So the foot's not being pushed down as much because it's being stretched at the back, so it's a bit flatter, and that area is being stretched. So often patients will come back with the results of the MRI scan and say, hey, I feel a lot better actually, it's kind of good. What do I do then? Well, if it's getting better and they don't want anything else, which I recommend, then great. Good luck and off you go. Hopefully it'll stay at bay. If it's not quite there, then my next step in escalation of treatment would be for an injection. Now I refer my injections to a radiologist to do, so it's a visualised injection on ultrasound guidance, and it's local anaesthetic and steroid. The local anaesthetic has got this immediate numbing feeling, which is a short-term thing, and the steroid, hopefully in conjunction with stretching and offloading the bones, will take down some of the swelling of the nerve, and maybe your definitive treatment, so hopefully nothing else after that. In the vast majority of patients, that's it, gold standard, done and dusted, which is great. The risks, so infection is a risk, failure to resolve symptoms is a risk, hypopigmentation, so the skin can get a little bit lighter, And skin dimpling, which I heard recently from a colleague who says that you can get fat necrosis. I've not seen it, but it's worth mentioning to patients or being aware of it as a patient as well. So those are the biggest sort of bits of this steroid injection. Hopefully it resolves. I generally see patients 6 weeks afterwards to check it's all worked and stayed at bay, in which case we can leave all well be. In the cases where it hasn't worked, that's when you consider taking the nerve out. If you're doing surgery, imaging is important. That's why I've got the MRI scan. So I've got this size nerve. There's a bursal neuronal complex, a bit of a swelling bag, a fluid around it as well. It helps me guide. I go through the top, it's less painful. I don't advise surgery in the first instance because it is quite sore and it's a lot of tissue to get down to. As you know, I'm a keyhole surgeon, but I don't do this through keyhole. It's an open approach, probably 2, maybe 3 centimetres. So it's a very, very small approach. Dissect down, take this out, take it out as far as possible that it's away from the landing area or the ball of the foot. So it's hopefully less likely to get entangled in scar tissue and have a recurrence. Recurrence is a risk, sadly, of this, because you can get a bit of nerve that swells up again, or the bursal or swollen bag as well that swells up again. And that can be quite irritable and maybe require further intervention. So ideally, avoid surgery at all costs. And I'm saying that as a surgeon. Try less invasive or non-aggressive approaches. So stretching exercises, dome orthotic, lots and lots of therapy. Get your feet down, get them stretched out around the back, don't load up the front. Have a look potentially at the way you're loading. If you're a runner, it may be worth seeing a biomechanical podiatrist who can advise on how you're impacting on the front, how that kind of action is affecting and creating these nerves. There's a whole host of information there, but it's a little brief synopsis on my thoughts on Morton's neuroma.